Started in just a moment. Hi, everybody. Thanks for joining us today. We're going to keep everybody on mute until our Q&A period today. So thanks for making sure you're on mute as we let people in from the waiting room. We'll get started in just a moment. Thanks everybody for joining us today, and thanks too for your patience as we let everyone from the waiting room. For administrative purposes, thank you for leaving yourself on mute until our question and answer period toward the end of today's webinar. We have a good group and I see a lot of new faces on our call today, so thanks so much for joining. We are the eConsult Workgroup. If you haven't been on one of our calls before, we've been around for about 6 years. We are a project supported by California Healthcare Foundation and our wonderful sponsors who we'll talk a little bit about later today. We have a full agenda, so I'm not going to spend too much time on this, but I just wanted to ask you, if you are new, if you wouldn't mind introducing yourself in the chat. If you wouldn't mind just sharing your name and organization, we'd love to welcome you to our group. We meet on a monthly basis, and we like to share published research along with programs that have demonstrated growth across the country. So we started out as a California-focused effort with a good number of California organizations, and now we've grown to be not only national, but international. And we have an attendee from West Africa on today, so I'm just excited to see our group grow. We'll start out with some policy updates. Robbie Franceschini from Blue Pack Health will share what's happening in California with advancement of eConsult policy. We're excited to have Dr. Lucinda Leong from UCLA, who's going to speak about eConsult and mental health. And in addition, adding to that topic, we have Dr. Ed Cladera and Pam Gould from Arista MD, who are going to share some examples of eConsult for mental health. Every month we share some resources, we share some publications that we found that are relevant to our topic, and we want to make everyone aware that all of these materials are available at econsultworkgroup.com. We want to stop for a minute and just reflect upon this past month. This, as you probably know, May is Mental Health Awareness Month. So we wanted to focus our effort this month and our material on eConsult for mental health. As we talk to people out in the field, as we work with FQHCs and public hospitals and others who are looking into and exploring expanding eConsult, one of the first questions people always ask is, can you do this for mental health? And so we're just excited to see that there are more and more examples out there of folks who are doing just this, and we're going to share some today. One last reminder, if you wouldn't mind keeping yourself on mute, we'll get started here in just a moment. I'm going to hand off to my colleague, Robbie Franceschini, who's going to talk a little bit about what's happening in California. So Robbie, go ahead.
Awesome. Thanks, Libby, and hi, everyone. Good to see everyone on the call. Just a quick update on SB 365. So just as a refresher, this bill, which is authored by Senator Ana Caballero, it would require for the Medi-Cal program to reimburse for eConsults for both the treating provider as well as the consulting provider within the Medi-Cal program, including providing reimbursement to federally qualified health centers and rural health centers as well. Currently, the policy is such that only the consulting or usually specialist provider can get reimbursed, and that is only within fee-for-service and managed care and excludes FQHCs and RHCs. So just some updates on the bill. It did get out of Senate Appropriations last week. It got off what's called the suspense file. So it's it's a unique hearing in that it's much like a cattle call, if you will, and they rip through all of the bills one by one and announce whether or not it makes it out of the committee and can move on to the Senate floor for a vote. I see a question did come in through the chat. This is a state bill. This is a California specific bill from Senator Caballero in the 12th district. Next steps include, some updates from the senator's office, particularly as to whether the bill will advance to a floor vote. We're still waiting on confirmation on that. The Senate Pro Tem, Tony Atkins from San Diego, has alerted all of her members that they are only allowed to move 12 bills forward out of appropriations this year. Senator Caballero has more than 12. So they're just working to prioritize. So we haven't received sort of final word on that yet. But stay tuned on that. And then I think really from there, next steps include floor votes in the Senate and the Assembly, as well as budget discussions around money to fund this for DHCS to be able to provide reimbursement for e-consult services. So I'm happy to take any questions if folks have them, and we'll make sure to keep everyone posted.
Thanks, Robbie. Yes, I would love to see some questions in chat if you have those. Thank you so much to Dr. Whitty from CPCA. Your comment is much appreciated. And those of you who aren't looking at the chat, Dr. Whitty shared that this invaluable virtual access to consultants is a dramatic improvement for access, training, and equity that has a great future as it grows and is supported by new and value-based payment systems. Thank you, Dr. Whitty. This is wonderful to have you as the leader of federally qualified health centers and helping us discuss and understand this bill better. We also just want to share these examples. You have these materials in your meeting request in your calendar. You have access to these slides and these links to the fact sheet and the bill language on SB 365. I notice here that we have folks in from Florida, from Nigeria, and also from Colorado. We also want to be that support for you as you explore policy in your states, and we love to have those discussions of what's happening across the country. So please do reach out if you'd like additional information on the discussions and the collaboration that we've had discussing this at the state level. So thank you for joining us, Tunisia from Maimonides, and David from Gainesville, and also Olagbegi from West Africa. Thanks so much. If I've said your name wrong, thanks and apologies. I don't see any other questions coming in, but please do share those, and Robbie and I can get back to you if you have any questions on State Bill 365.
Thanks, everyone.
With that, I'm going to hand off to Dr. Leung. And Dr. Leung, if you wouldn't mind taking yourself off mute, if you are still on mute, we want to note that we really appreciate the leadership that Los Angeles and the Los Angeles e-consult effort has given us as a work group over the past 6 years. We work closely with a number of providers that have been delivering and are experts in e-consult. And so we noticed, this was just exciting to see as we looked into e-consult for mental health, that Dr. Leung and her colleagues had published on this, and we wanted to spend a little time focusing on their findings on how mental health and primary care have been integrated through e-consult. So Dr. Leung, I'll let you introduce yourself and go ahead, and I'll advance your slides for you.
Thank you so much for that generous introduction, Libby, and I'm really excited to meet with you all today virtually. So I am a health services researcher based out of UCLA, and I've been collaborating with our LA County Department of Health Services and Mental Health Leadership on research for a number of years. And I'm excited to share with you today some of our findings. And I'm not going to be focusing only on e-consult, but I'm going to talk about how e-consult fits into the work that we're doing as a whole to improve communication and services between primary care and mental health specialties. We can go ahead and advance the slide. My funding is disclosed here. I have no other conflicts to share. We can move forward. So first and foremost, I'm a primary care physician, and I am a user of e-consults. And I find that patients that I care for that I often struggle with are patients with comorbid physical and mental health conditions. Fortunately, we know how best to take care of these patients. More than 90 randomized controlled trials show that collaborative care models are effective. And these models embed care management services allow psychiatrist consultants to work directly with me in clinic in primary care, and directly in clinic nowadays can be virtual as well. We are at the point, since it's been decades since that first trial with the positive outcome, on how to disseminate and implement these models in real world settings. And so today I'm going to share with you what LA County has done for its safety net clinics. Next slide, please. So a little over a decade ago, our departments of health services and mental health worked together to roll out evidence-based mental health integration program. Across LA County, DHS, we had 19 primary care sites. 10 of them continued on care as usual with separate services from both departments. But next, the 9 larger sites offered integrated services in a staggered fashion, as you can see on the bottom left, over a several year period. Next, please. What does integration look like? Well, screening for mental health disorders like depression, anxiety, trauma became universal at these sites. Next. Medication management for these conditions became more robust with the addition of care management services predominantly offered through licensed clinical social workers and with easier access to a psychiatrist consultant. Next. And finally, integration facilitated the flow towards specialty care and even allowed for evidence-based psychotherapies to be offered on a short-term basis directly in primary care. Next. So very few public health systems have been able to document quality outcomes from wide-scale implementation of integrated mental health care. Los Angeles County Department of Health Services is the nation's second largest public health system. Our Department of Mental Health Service, our Department of Mental Health is the nation's largest mental health system. So this is a neat opportunity to be able to document the work that they are doing and to explore and see whether this program, as pragmatically rolled out, had any effects on outcomes for patients. So today I'm going to share with you 3 things. We're going to compare the primary care visits before and after MHIP implementation in these clinics, and to see whether there was a higher number of psychiatric diagnoses associated with those visits. We're going to look at whether implementation of MHIP was associated with better depression treatment initiation among our safety net patients. And we're going to round it out by talking about the role of e-consult and other technologies to help facilitate the integration between primary care and mental health. So next slide. So for those who are not familiar with Los Angeles County, again, one of the largest counties in the country, we had 19 clinics spread out the county. You can see from the black dots on the map on the right that they're a massive distance that we're covering. And we looked at a time period about a decade ago when this program first rolled out from 2009 to 14. Our study included over 250,000 unique patients that used primary care at least once. And we merged data from both departments of health services and mental health, administrative, medical records, pharmacy data, we had it all. Next. Just an example of who we are looking at. This is truly a safety net population. Most are middle age, larger proportion of women, heavily Hispanic, and Spanish speaking made up nearly half of our patients. They were mostly healthy, and majority of them were uninsured and or if insured by Medicaid. Next. So how we're doing this study is we're simply taking the clinics that implemented mental health integration MHIP, and we're looking at their visits before implementation, which is the area in the bottom left, light gray. And we're comparing those visits to the visits after implementation, which is the area on the top right that's black. We buffered out the time about 6 weeks before and after integration, to let clinics kind of work out the kinks. But we are comparing those visits before and after. Next. And this is nearly 700,000 visits that we looked at. And among those visits, less than 10% were associated with a psychiatric diagnosis. The majority of those visits were made up by visits for depression and anxiety, unsurprisingly, and very few were associated with alcohol and substance use disorders. On the right, we're seeing those different types of diagnoses broken down by whether the visit occurred before or after implementation. And you can see from the bars, the dark bar being after implementation, those rates were much higher. Next. And we want to make sure we fully control for all factors that can influence the outcome. So we made sure to adjust for patient demographics, whether they had insurance, how sick they were with the Charlson Comorbidity Index. And after we did that, that difference shrank a little bit, but was still statistically significant. Next. So you can see here that the odds of a visit having a mental health diagnosis increased by 9%. For a new mental health diagnosis, it increased slightly more by 11%. And much of this was driven by the most common mental health diagnosis that we see in primary care, which is depression. Next. Now, it's unsurprising, but mental health services use, there is a clear racial ethnic disparity that exists across many health systems, and we saw this as well. Odds of visits being associated with the psychiatric diagnosis was much lower among our minority patients compared to our white patients. And you can see predicted probabilities shown on the figure on the right, with the blue representing Asian patients, the gray Black patient, light blue Hispanic patients, compared to the highest, which is Black column, which is white patients. Next. And odds of visits being associated with the psychiatric diagnosis was also lower, about 20% odds lower for our Spanish-speaking compared to our English-speaking patients. Next. Okay. So, we know that, having a diagnosis coded to a visit doesn't necessarily mean that treatment was delivered. So we wanted to look at that question more precisely by focusing on the most common mental health diagnosis that we saw in among our patients, and that was depression. So we wanted to make sure anybody with a new diagnosis of depression, they didn't have that diagnosis the year before and they just get it in primary care. Are these patients getting timely treatment for that diagnosis? Within 90 days, are they getting medications as found in pharmacy data? Are they getting a mental health visit as confirmed by mental health records? Next. So looking at the raw numbers, about 30% of people were able to start anything within 90 days. And in the figure, you see 3 columns for each of those outcomes. The first blue column represents clinics that never had MHIP, never had integration. And the subsequent 2 columns, the gray and the lighter blue bars, represent clinics before and after implementation, with a noticeable jump up after MHIP began. Next. That was largely driven by starting medications. Next. And only 3% of people ever reached a mental health specialist. Next. So among these, 30,000 patients with new depression diagnoses, we adjusted for patient sociodemographics, insurance, how sick they were, and we're finding that the gap from before and after implementation of integration really even expanded. It's a very clear difference that's statistically significant. Next. The odds shot up about 2 times as high starting anything within 90 days of new diagnosis of depression. Again, mostly driven by medications, as we saw no change in odds of seeing a mental health specialist. Next. So we again examined racial and ethnic disparities, and we're surprised to see sort of a reversal. Minorities were starting treatment more often than white patients when we account for medication. Next. So it really should be thought of as medication initiation is higher when it comes to treating depression. Next. Again, we saw a reversal with Spanish speakers and English speakers. And next, it's really, they're more likely to get treatment started, and that treatment is medication. Next. So these findings are really cool to share because these programs were implemented, pragmatically. They look differently from site to site to site. There are a ton of barriers to overcome, and yet we found fairly positive findings, in my opinion. So let's dive a little bit into those barriers and how they can be further overcome, and to discuss in the last part gaps that could be addressed. So MHIP, not yet, there you go. MHIP depended on specialists to provide as needed psychotropic medication consultation and short-term psychosocial treatments. But there are a lot of barriers. There are different scheduling and documentation systems between both departments of health services and mental health that made it really hard for referrals to even happen, and for scheduling to occur, and for providers to communicate. On-site staffing was inconsistent, and a lot of it was related to just not having physical space in clinic for specialists to be in. And that really prevented broader care management for our vulnerable populations from happening. You guys can see where I'm going with this, because the next slide I share with you, we can move on, how e-consult can really bridge the gap there. And this is, I'm preaching to the choir here, having the ability to provide electronic consult and referral for mental health, albeit it is a very difficult thing to do when the departments are completely different, it was something that needed a lot of work, but ultimately happened after the, our study in 2015. And once implemented, the median response time when we had looked at it during the first 2 years was under 2 days. 13% of visits resolved without requiring an in-person visit. And what you'll notice here in red is that the majority of visits that came from e-consult mental health were being funneled to integrated mental health care. The schematic that we have on the slide here, I'm not going to spend too much time walking through, because they're probably similar to e-consult systems that you have seen as well. But it's just to show you that creating an e-consult system for mental health is really different from creating an e-consult system for other specialties, because of the various ways that mental health and medicine are sort of siloed, not just sort of administratively with departments, but also with the way health insurance is carved out for behavioral health benefits and such. And in Los Angeles, the Department of Mental Health doesn't even deal with substance use disorders, and those services are being provided separately from the Department of Public Health. So having e-consult mental health in place is really something that it required a lot of effort and leadership support and on the ground work. So next slide. One thing is for sure, having e-consult mental health there helped PCPs a lot with prescribing medication. Having the ability to communicate with the psychiatrist meant we could treat medications treat patients in primary care with medications with more specialist backup. But the problem is most people prefer therapy. And when we did a survey in Los Angeles County around the same time of this study, that number was close to 70% preferred psychotherapy. And for minorities, for Black patients, that raised up to 2 times the preference. Next. So how do we do this? How do we deliver psychotherapy to the primary care population? We can cut psychotherapy so that it's shorter. Psychotherapy is traditionally an hour long every single week. You come to see your therapist, but in primary care, we can deliver it in half the time, in half the sessions. And that's essentially what MHIP was doing. Next. And this is no surprise to everybody after this past year, but we can deliver mental health services virtually as well. The research supports this, and everybody's lived experience from this past year probably does as well. Next. And the research that I'm doing right now is trying to push the borders even further. What if we could move depression therapy completely online, or at least the majority of it online? So there's a concept that has been very well studied, supported by more than 40 randomized controlled trials, of computerized cognitive behavioral therapy. It's available 24/7 online via a desktop or a mobile app. It's even been found to be non-inferior to face-to-face therapy, especially when there's appropriate clinical supervision that is provided in an asynchronous manner. There are different vendors, and those are the pictures that you're seeing on the bottom of the screen there. Next. So this is what I'm funded to study at the VA right now. I'm introducing computerized therapy into our collaborative care models. I recently completed stakeholder interviews with our mental health and our primary care clinicians, and focus groups with our veterans to see how best to design this in our health system. The reactions that you see pasted here, are fairly positive. Nobody really felt strongly that this is not something we should be doing. And most folks were pretty accepting of this technology, I think, because of this past year and the understanding that we are moving into a virtual age. Next. So we talked a lot to round it out about how we can work smarter with the help of technology, and not necessarily harder, requiring a lot more money, manpower, and resources. We talked about patient-facing technology with the computerized therapy on the left of this figure. We talked about building primary care capacity to treat behavioral health conditions in the middle with regards to e-consult, and virtual visits, telehealth. That is something that is just here to stay, and we have to figure out how much of that to balance with the face-to-face visits we need to do. Next. So in conclusion, collaboration between two large distinct health systems and its resulting integrated care program yielded increased primary care visits associated with psychiatric diagnoses, increased depression treatment initiation among our safety net primary care patients. And it's really exciting to look to technological innovations, including e-consult as a platform to deliver a lot of them, to augment existing primary care models, and to increase mental health care access for our safety net patients. Next slide. And this is especially important as we consider how rates of depression, mental health problems are, just soaring in relation to the COVID pandemic. Our safety net patients are disproportionately burdened by this infection. And next, we are fighting against the fourth wave very soon, the emotional toll that this pandemic has taken on our patients. So we need to be ready with the infrastructure to treat these problems. Next. And I'm just going to end by thanking all my co-authors on these research studies that I've shared with you, listed here, many others who aren't on papers that I've published, and to stop and take any questions.
Thanks, Dr. Lang. I have one question that's related to this last slide. I'm going to just skip back here for a moment. Amy Peterson from San Francisco asked, what's changed since COVID? I think some of this is on this slide here, but her question specifically is, this telehealth video or telephone visits changed real or perceived need for in-person? I'd add e-consult to this. Has e-consult or any other modality of telehealth changed people's expectation for a face-to-face visit? But I'll let you take that one.
Yeah, I can speak a little to this from the VA health system in Los Angeles where I work. And it, I think, pretty much applies to a lot of other health systems too. When the pandemic hit, we all sort of went virtual. Those peaks and troughs kind of came and went depending on when we had the surges. I think where things will shake out right now is what we're all wondering in this kind of nearing post-pandemic era. How much of e-consults will be there as the norm, how much of virtual visits will be there compared to face-to-face visits. I think that again, a lot of it depends on the health system, because at least in the VA, we are reimbursed the same for telemedicine versus face-to-face visits. E-consults we get credit for as well. So that obviously I think puts us at an advantage to using these less traditional virtual modalities. But I think we're getting there with other systems too. This is just the way it's going to be. Patients prefer it. It's clinicians enjoy working remotely too. So yeah, I think it'll depend. I don't think I have a magic 8-ball to tell me how it'll all shake out, but it's definitely not going to go back to the way it was.
Right, and we've heard so much more interest in looking to e-consult for mental health since COVID. So a couple other questions here. Danielle, I think that's Danielle Carter. I'm not sure if that's you, but Danielle asked, how are other members of the care team, like care managers, looped into the e-consult exchange between the PCP and specialists? Would you imagine care managers might be able to send e-consults as well?
Yeah, so I think right now, at least in my health, I think in at least in the VA and Los Angeles County, they're primarily tools used by primary care providers to specialists. That said, I don't see why that couldn't be extended to other team members within primary care. Because we are moving away from the lone PCP, acting on behalf of the patient. Primary care has really become a team sport, and the collaborative care models that I've showed, care managers were really part of the primary care team, even with their mental health training. So that may be something that is on the horizon, but I don't see currently happening right now.
Thanks. Another question, I'm sort of rattling these off because we have a few more. So Alig Megi from West Africa asked, there's sort of a common thread as throughout our e-consult work group that we look to payers to be able to support these efforts, and we appreciate, especially in California, medical managed care plans have been really supportive of these efforts. And Dr. Leung, I'm not sure if I might have missed this. Are these programs that you have worked in, are you seeing all types of coverage? Are you seeing uninsured patients, Medi-Cal and VA, or is this limited to a certain membership type?
Yeah, so I work within the VA system. I am not currently working within the safety net system, but I have in the past. And the safety net system takes, I even have a slide previously that showed the different types of coverage. We take private insurance, Medicare, Medicaid, but just the majority in the sample that I showed here, 60% had no insurance.
That's really important. Thanks for emphasizing and noting that it covered all patients. So thank you.
I will say that I think that in integrated systems like the safety net and the VA, it's easier to work with these technologies because of almost a lack of concern for reimbursement as much as the private setting.
Good point. And we're working on that as part of our work group, and we welcome other states who are navigating those challenges too. Another question from Amy, which is a great one. What does this mean for other improvement initiatives like warm handoff to behavioral health team members? Do you think MHIP works in addition to something like a warm handoff or better? And I'm sure you can see the question, Dr. Leung, but maybe you can address that.
Yeah, so if the warm handoff is something that in traditional collaborative care models is very important. Just having someone that as a PCP that I can walk down the hall and talk to and ask questions of. It's been very challenging the past year figuring out what the warm handoff looked like. And I'll speak anecdotally to my own experience where in primary care, I'm still sitting here in the hospital. Mental health is, went virtual very quickly and everybody was gone. And I was trying to simulate as much of a warm handoff as possible with like instant messaging, phone calls, getting the care manager and the psychiatrist to kind of join into my video visit. It gets much more complicated now that I can't just walk down the hall. And how that's going to look like going forward, I'm sure that the technology will evolve to make it more seamless for us to interact with people. I mean, we've been Zooming for like over a year now routinely. So yeah, I don't think that the warm handoff can be replaced, but I think it will have to evolve with the technology.
Thanks. Dr. Land, this has been so helpful to see this detailed, your detailed information that you've gathered on this. I just want to ask one last question. Maybe you can bring this all together for us. You did bring up the fact that this is not simple. You know, there are many moving parts. There are so many different stakeholders in integrating mental health and primary care. Any final recommendation as other systems might try to approach a program like this?
Yeah, I think exactly what you touched on, just knowing all the different stakeholders involved. You can't just do integrated mental health programs from the lens of mental health. You really have to involve primary care at the table. And then you also have to consider mental health, it also includes substance use problems and addressing that and making sure those folks are at the table. And the patients as well. I mean, at the end of the day, they're the ones that we are doing all of this for, at making sure that they have a voice. So I think engaging stakeholders early, often, and continuing to refine models, and then thinking about where technology can fit in. I think that's sort of the path to making these models better.
Well, that was a great transition to our next presenter, Dr. Leung, and appreciate your time today. There's so many questions coming in. We have a few more we didn't get to, but I'm going to connect offline and make sure we get those answers to these questions. And we are really appreciative of your time today. Thanks again.
Thank you very much.
And those of you who'd like to connect, you can see Dr. Leung's contact information here. Thanks again. And Dr. Leung just brought up the point that it's important to consider, all different players at the table. I think we're going to talk a little bit now. I'm handing off to Pam and Dr. Cladera here, who are going to talk a little bit about behavioral health and primary care examples of communication. So good cases of mental health and behavioral health integration and communications between providers. So Pam, I'll hand it off to you to introduce.
Excellent. Thank you, Libby. Yes, Dr. Leung, thank you, because you really did help to set the stage for the example cases that we're going to be presenting that really illustrate the use of e-consults in treating mental health as well as behavioral health conditions. Some things to consider when we talk about, and it really reflects back on the conversation we just had, but things to consider when you're thinking about an e-consult program, particularly surrounding mental health. We all know there is a shortage of behavioral health providers, and we hear this across the board as we're talking to different folks. We're working with clients in the various states that we're in. The wait times that patients are, having to undergo before they can actually get to a psychiatrist, a psychologist, get any type of mental health treatment can be months. And so, depression, anxiety being a very common illness that we see, as Dr. Leung had mentioned, in the primary care setting, it plays a critical role utilizing e-consults in being able to equip the primary care providers with what they need to recognize and treat depressive symptoms and or anxiety symptoms that come up. What we also know is that about 80%, when we look at PCPs, they're providing about 60%, as Dr. Leung had mentioned, of mental health care, and prescribe almost 80% of antidepressants, with depression being one of the #1 conditions that they are presenting with, patients are presenting in their clinics with. And then also we know that primary care providers have an opportunity to identify things like suicide risk, prevent death. And with many patients who have had an attempted suicide, when they visited their PCP within weeks, we've seen that those suicidal ideations were actually resolved or addressed. So PCPs are creating they have a established relationship many times with the patients. They have this believability factor, if you will. There is a connection there. And so the PCP as a central point for treating behavioral health and mental health conditions is really important. And this is where e-consults can come in. They become a great resource to be able to reach out to specialty care psychiatrists, psychologists, could be adult pediatric specialists, it could be addiction specialists, to be able to help with medication management, titration, or even determining if the use of adjuvant therapy and drugs would be beneficial in symptom management. And then, as Dr. Leung had mentioned, when you integrate e-consult into a really robust program where you can actually help to drive and direct patients to other modalities of treatment and psychotherapy, like telepsychiatry and other types of programs, they can be invaluable. So what I'd like to do now is, on the next slide, is have Dr. Cladera take us through some of our actual cases that we've had here at Arista MD. All of these are de-identified, but to give you a sense of how e-consults are being utilized in this setting. Dr. Cladera?
Thank you, Pam. And I'd like to echo what has already been said, in the sense that most of us in the clinical world understand that there's a deficiency in behavioral health access and also implementation because of lack of access. Arista MD is trying to lower that barrier. I also wanted to make a notice. The leadership of Arista MD is so supportive. Our own CEO is also on the call, Brooke Lavisseur, which shows how much interest Arista MD has in providing services to our clients and our patients that we service. So without further ado, our sample e-consult is initially looking at adult psychiatry, specifically insomnia. Most of us have experienced insomnia, whether it's transiently or episodically, but a lot of patients experience it chronically. And this primary care providers reach out to an Arista MD panelist in psychiatry to get better information for the patient. So the framework is, this patient has been on Ambien for about 10 years. They unsuccessfully tried to wean themselves off of this Ambien medication 6 years ago, did not tolerate it. So the main question is, do you have a recommendation or any suggestions of being able to wean a patient off of Ambien? Any ideas regarding rebound insomnia? Again, patient tried 6 years ago after the loss of her husband. So the widow is having difficulties retaining sleep, but also wants to be weaned off of Ambien. Next slide. Thank you. So in summary, there are treatment options available at the primary care level. About 73% of the time, our panelists are able to give directions such that the primary care provider can maintain the management of the patient at the primary care level setting. The specific recommendations that the psychiatrist had for this particular primary care provider was to approach the weaning of Ambien as if it were a benzodiazepine taper, benzodiazepine medications like Xanax, Ativan, Valium. She's been on it for a long time. The taper is going to have to also be done. A weaning needs to be done on a slow basis, given that the patient's been on it for a considerable amount of time. Now, the beauty about e-consults is where the specialist is able to give potential pitfalls and items to look out for. In this particular case, hopefully there'll be no rebound insomnia that will occur. This specialist did a tremendous job on the examples there in the midway. They provided the recipe for the weaning. So weeks 1 through 4, a certain amount, weeks 4 through 8, a lower dosing of Ambien, and weeks 8 through 12, a very minimal, almost the smallest dose possible that you could provide safely to a patient with Ambien before the wean is completely discontinued. There was also some patient education, which is super important to note. Items of concern, long-term usage, some rebound insomnia. Patients also was made aware of any rebound insomnia, and could also be provided adjuvant medications over the counter. The the specialist also mentioned some medications such as doxepin, gabapentin, and also provided medications such as Romaltian, which can be started. These are prescribed medications that can help with insomnia or rebound insomnia when the patient's being titrated. And also, the specialist also provided some discussion regarding sleep hygiene and some sources out of the University of Washington that the primary care provider could potentially provide that patient, or talk about some sleep hygiene and items of concern that could optimize the patient's success in being weaned off of Ambien. We also have another sample, a consult on adult psychiatry regarding depression. This is a case framed as a follow-up visit that the patient's depression unfortunately has been poorly controlled. Patient has unfortunately anxiety, fearful thoughts, fatigue, denies current death or suicides. However, the patient has significant risk factors: family history of depression, family anxiety, her own history of depression, and medication used to try to manage that depression. There's also patient's risk factors: alcoholism, child abuse, and the list goes on. Very unfortunate circumstance. The patient denies any chronic pain, headache, or irritability. She is currently taking an SSRI, Paxil 20 milligrams, and wants to switch over to a newer version of antidepressant medication. The primary care provider is reaching out to the psychiatrist for guidance. No recent labs in the chart, though a SOAP note was attached. So the main question: can the primary care provider please receive recommendations on medication tapering and also transitioning to a different type of SSRI or anti-depression medication? Next slide. Thank you. So the psychiatrist did, again, a wonderful job, initially stating that there are treatment options available at the primary care level. The specialist is also suggesting pursuing other differential diagnoses that could be adding to the patient's depression, such as making sure that hypothyroidism is not a culprit, to consider checking a TSH. That could potentially be a contributor to depression and anxiety if the patient does have underlying hypothyroidism. Specifically, the specialist gives recommendation to the primary care provider that'll be forwarded to the patient to transition off of Paxil and onto Lexapro. It needs to be done in a gentle transition where the medication Paxil needs to be continued while the new SSRI, Lexapro, is initiated, and for there to be about a 1 week overlap before Paxil is completely discontinued. Down below, recommended patient actions. The specialist gives adjuvant recommendations: encourage exercise, taking the dog for a walk, encourage participating with pleasurable activities. Who doesn't want to do that? But oftentimes in a busy world, patients, including ourselves, forget to do that. Hobbies or time with friends and family. Also follow up 4 to 6 weeks after starting medications for changing dose. So one item that AristMD encourages our specialists is if they could provide not only a clear, concise recommendations, but also provide educational pearls and also put on the primary care provider's radar potential pitfalls as well.
So, Dr. Cladera, I wanted to leave some time for questions, and
Absolutely.
I want to open this up for folks to send their questions via chat. One thing I really appreciate about these slides is often we get questions from providers about, what are examples of good communications or exchanges between a primary care provider and specialist. And so I really appreciate your cases and the examples of the detailed responses, the time that the mental health professional took to really provide a detailed response for the primary care provider. Do you have any recommendations on, what do you tell to your primary care providers and specialists to prepare thorough responses, especially around mental health? Is there any tip or trick around optimizing those communications between primary and specialty care providers?
Great question, Libby. And I think it starts off with a good question from the primary care provider, a question that's clear, a question that is supported by any subsequent documentation, a SOAP note, a history and physical. And if the question is based on medications, a thorough review of the patient's medications would be helpful as well. That way, the specialist has the information to formulate a good strategy, a good response to that primary care provider so that the patient could ultimately have successful outcome.
Great, and that's really helpful. When you coach or when you orient a provider on how to write a good e-consult question or response around mental health, are there any nuances or differences? Obviously, mental health treatment is sensitive. Is there any advice that you would give to those who are trying to do effective mental health e-consults?
That's another good question. What I would encourage primary care providers to do is not to be shy to reach out for help. Primary care providers are frequently in the trenches. Pam gave the accurate statistics where 80% of medications prescribed in behavioral health patients are done so by primary care providers. Don't be shy to reach out to our specialists, whether they be psychiatrists, psychologists, or RISMD has both on our panel, and they can provide a world of information, not only on the management of medications, but when would CBT, cognitive behavioral treatment, be a good adjuvant for the medication. And they're also able to provide educational pearls and also put on the primary care provider's radar potential pitfalls of when is a particular patient beyond the scope of practice for a primary care provider, in the sense that they need to see a behavioral health specialist or possibly even go to seek immediate medical attention in the settings of suicidal ideation. Good question, Libby.
Well, I really like that last point that you shared with us, that we talk about e-consult as being for routine questions, and in the case of behavioral mental health, I'm sure that you come upon cases that require immediate attention, and that's a very good point, that you can still do an e-consult and realize that that patient needs more attention or a different type of treatment than can be resolved via e-consult. So thanks for bringing that up. And I really appreciate these examples today. Pam, did you have any words in closing?
Now, just to reiterate what everyone has been talking about here, I think the use of e-consults has a definite future and certainly a growth potential when we look at the behavioral health space, especially with mental health and especially concomitant programs, things like digital therapeutics, CBT therapy, positive psychology, all of the different things that we've talked about for psychotherapy. I think when you look at a wraparound solution for mental health, this is where we're going to get our biggest impact. And it's also going to be how we address concerns like cost, folks who are uninsured, some of these disparities that we see that are occurring in healthcare. So I'm really excited about the direction that we're going in. And I was thrilled that we had the opportunity today to really dive into this. So thank you, Libby.
Thank you so much, Pam and Dr. Cloudera, for your time. Really appreciate your involvement in our work group. We just want to share a couple of quick announcements as we wrap up today. And we want to be this resource for you when you want to bring new providers into a program, make them feel comfortable with this process. And Pam and Dr. Cloudera's examples are good ones today of examples we can provide of best practices. Over the past few months, we developed a CME course with Darren Anderson and Delphine Tuo, who are experienced e-consult providers. We would love to be able to offer this. This is a free opportunity for providers. When interested, if you have a group who'd like to set up a CME course, we're happy to schedule this for you. As you can tell, it was very highly regarded. We had a session back in March that was embraced by providers and very successful. So please do reach out if you're interested in CME. We, as you know, if you see your email, you get a lot of emails from us, I know, but our monthly e-consult news we do our best to share what's coming out, what's most recent in terms of publications around e-consult, and wanted to, with the month's theme of mental health awareness, wanted to point out that there is some interesting work out there with regard to e-consult for addiction and SUD treatments. We found this study very interesting this is actually out of an Asian health journal. However, it showed the integration between Project ECHO and e-consult, a great example of different programs working together to address mental health. And we do want to give one last shout out to our sponsors who make this work possible. Thank you all for supporting our work. We're looking forward to getting out of our the year of challenges, seeing a light at the end of the tunnel and being able to meet in person, we hope, in November. So please save the date, November 9th and 10th. We'll meet in any way we can, whether it be in person or virtual, for our annual meeting. And thank you again for your support. Last, if you do want to have access to this presentation recorded and slides, you can go to econsultworkgroup.com for updates, our webinar information, and any policy updates along with our recent publications. Thank you to Michelle Canales, who joined us from Senator Caballero's office. And we look forward to hearing what happens with State Bill 365. We'll keep you posted on the next call. And you'll receive an invite for our June eConsult webinar soon. Thank you everyone for your time today.